Rahim. Good evening, dear professor and colleague. I would like to thank the success of yesterday, the organizer committee, the scientific committee of our conference. Now, special thanks goes to Sandoz Group, giving us the opportunity to share this experience for optimum selection of endocrine therapy in hormone-based breast cancer. The objective of this presentation is to give an overview on the landscape of scientific evidence, guideline, recommendation, and treatment option for a segment of relatively good prognostic breast cancer women with hormone positive. Cancer in general is the second highest cause of death worldwide after ischemic heart disease. Breast and lung cancer are the highest, followed by colorectal cancer. In Egypt, breast cancer is the second highest incidence type of cancer, following the liver cancer, which is considered a special scenario in Egypt and a special heart problem due to hepatitis C, which is expected to steady in upcoming years to decrease with the effort exerted for diagnosis and treatment of hepatitis C. Breast cancer in Egypt is contributing to more than 1/3 of the cancer in women. Worldwide, breast cancer death is the 5th rank, but in Egypt, unfortunately, it is the 2nd, maybe due to late presentation or suboptimum management. So, the high adoption of the guideline is usually recommended to decrease the tumor burden. In hormone positive, generally represent 70% of all breast cancer, and endocrine therapy is the mainstay in their management and protocol. In HER2 positive, in hormone positive, HER2 positive breast cancer, as you see, all patients should receive adjuvant endocrine therapy as an upfront or after chemotherapy or as per TN classification. The same in node negative, HER2 negative breast cancer, the endocrine therapy is the mainstay in their management. And the same as well in high-risk patients with hormone positive, node positive, HER2 negative. So we all know quite well that endocrine therapy is the mandatory in all. So let's start to optimize the selection based on patient profile, and the duration also is the most important and controversial thing. In premenopausal women, 10 plus minus ovarian suppression, or aromatase inhibitor for 5 years, then evaluate if still premenopause continue for 5 years or stop. But if the patient become postmenopause, continue on aromatase inhibitor at the highest evidence and the class of recommendation, then continuing to TAM for another 5 years. Okay, the situation is different in postmenopause. The recommendation is AI preferred as a category 1 for 10 years, or you can start to 2 to 3 years of TAM, then complete it 5 years with AI. Another lower class of recommendation is to start with TAM and then continue with aromatase inhibitor. As you see, The preferred endocrine therapy in postmenopausal women is aromatase inhibitor than TEM. As we see in NCCN guideline, let's see what is the evidence behind this. The meta-analysis for breast cancer women with hormone-positive treatment and postmenopausal to show the comparison of AI versus TEM showed the superiority of AI in the recurrence either as initial therapy or after 2 to 3 years of TEM. So we have just seen why aromatase inhibitors are preferred over TEM. The NCCN is recommending that the 3 aromatase inhibitors have the same similar anti-tumor activity and toxicity. Let's see the evidence. Letrozole didn't provide a statistically significant superior efficacy over anastrozole in either the efficacy or toxicity, as shown in phase trial, illustrated in front of you. Exemestane as well showed non-superiority over the non-steroidal AI. So letrozole, exemestane failed to show superiority over anastrozole. In ATTACK trial, anastrozole significantly improved the PFS and time to recurrence over TEM in almost 7 years analysis. The superiority is maintained in 9 years analysis with more diverge, as you see, with passing time, more diverge of the curve. While the NCCN recommended to switch patients who started with TEM to IA, like anastrozole, this is because there is a short benefit in this meta-analysis of the 3 trials in terms of event-free survival and translated to overall benefit. That after having an overview on treatment option and highlighting the value of AI in postmenopausal breast cancer, let us to discuss a hot topic. What is the duration? The adjuvant ET is for how long? A recent retrospective analysis of Oxford University studied the risk of recurrence after 5 years of hormone therapy. They found a considerable risk of recurrence up to 20 years after the initial 5 years of endocrine therapy. So they think that extended years of endocrine therapy is not luxurious. The risk is there and continued steadily over years up to 14 years after the initial 5 years, even in T1N0, which is considered as a low-risk patient for recurrence. So let us to discuss the result of Atlas trial, 10 years, TEM better than stopping at 5 years with regard to recurrence. Another very important trial, not only TEM, but AI as well, in MA17R trial, which conducted that extended AI adjuvant treatment is considered safe and beneficial. How safe? Was 10 years versus 5 years. No significant difference except in bone age, 18% versus 14 in placebo, as you see. Also, significant liver enzyme elevation was reported and the bone fracture as well. Osteoporosis is a very crucial and important issue with prolonged AI, which are really significant, but actually not very high. Yet, prevention of osteoporosis is a very important issue for those patients. How safe was the 10 years versus discontinuation on 5 years? No difference in adverse event after the study drug discontinued. And this is a very important issue. If you are really convinced by the study, the guideline, recommendation, not everything is now solved. An important thing is the patient adherent to your medication. In Canada, 93% of patients were adherent at 5 years. The men were adherent at year 5. The main reason of non-adherence was side effect and convention, which is our role as a treating physician. In China, in this study of endocrine therapy adherence, the result showed that, unfortunately, the non-adherence is accompanied with poor clinical outcome, as you see. The main reason among the Chinese were side effect and fear of side effect, and like Canada, doubt about treatment efficacy. The study outlined the key cause of non-adherence, either patient-related factor or medicine-related factor, while focusing as recommendation that patient education and management of side effect are the key steps by which healthcare provider can help and improve treatment compliance. So, a healthcare provider play a crucial role and part of adherence, not only the patient. Let's have an overview of endocrine therapy in metastatic breast cancer. Endocrine therapy is the mainstay as well in metastatic breast cancer with hormone positive, either in HER2 negative or positive. As illustrated is a very busy slide, but metastatic breast cancer with hormone positive, HER2 negative, the preferred treatment are 3 options. AI plus CDK4/6 inhibitor, selective estrogen receptor downregulator as fulvestrant, plus minus aromatase inhibitor, or fulvestrant plus CDK inhibitor. This is Monarch study studying abemaciclib as CDK4/6 inhibitor plus aromatase inhibitor was effective as a first line in advanced breast cancer. In Monarch 7, ribociclib plus endocrine therapy was better in progression-free survival with manageable toxicity than endocrine alone in 13 months result. In 4 years, the analysis of Mona Lisa 7, ribo plus endocrine therapy was better in PFS as well as overall survival with high divergence in the curve, as you see in the curve for more than 30 months. And now, to tackle the second preferred option in the first line, hormone positive metastatic breast cancer, fulvestrant plus minus aromatase inhibitor or aromatase inhibitor. Falcon study demonstrated that fulvestrant was better in progression-free survival as median PFS was 17 months. And now to the third preferred option on first-line treatment in hormone-positive metastatic breast cancer, HER2 negative, fulvestrant plus CDK4/6 inhibitor. CDK inhibitor plus fulvestrant was significantly better overall survival than fulvestrant alone. The result of fulvestrant alone. In Balluma 3, fulvestrant plus bicycline who progressed on endocrine therapy had longer PFS than fulvestrant alone. In second-line option, fulvestrant plus CDK4/6 inhibitor, if not treated previously in first line. Other option, as you see, aromatase inhibitor, fulvestrant, or even TAM. We have another option like everolimus plus endocrine, non-steroidal aromatase, anastrozole, etc., etc. Okay, in HER2, in hormone positive, HER2 negative breast cancer, AI, fulvestrant, or TAM plus anti-HER2 therapy. As a conclusion, breast cancer is the second highest incidence and the second most leading cause of death in Egypt versus the fifth cause in worldwide. The three selective aromatase inhibitor, anastrozole, letrozole, or exemestane, have shown similar anti-tumor efficacy and safety profile in randomized trial. Meta-analysis of switching from TAM to anastrozole confirmed that clinicians should consider switching, especially in post-menopausal women who have taken adjuvant TAM for 2 to 3 years to anastrozole or any AI. Even after 5 years of endocrine therapy, recurrence risk continued to steady over 14 years, even for those with low risk grade and TN. The extension of treatment with adjuvant aromatase inhibitor to 10 result in significantly higher rate of disease-free survival than those of placebo. Healthcare providers play an important part for adherence of the patient to the treatment by communicating and clarification the side effects of AI to the patient before initiation of the treatment, as well as explain to your patient the strategy for addressing this side effect. Ribo plus endocrine therapy improved PFS compared to placebo plus endocrine therapy and had manageable safety profile as all CDK inhibitor in patients with premenopause, hormone positive, HER2 negative, and advanced breast cancer. And thank you.
Thank you, Professor Lob.